Hey everyone, and welcome to the lecture discussion on orthopedic injuries. We're going to be talking today about basically the musculoskeletal system, particularly the skeletal system, and in particular, we're going to be looking at splinting and caring for skeletal injuries in wilderness scenarios. So let's get started. We're going to put him off to the side for a second, and I am actually joined in this conversation today with my lovely wife, Dr. Sharon Stekna. So come on over here, Sherry. So unfortunately, this means I'm not going to be able to just lie and bullshit my way through this because she has a medical degree, so I'm actually going to have to say stuff that makes some reasonable sense. But basically, what we're going to do today is we're going to look at bones and when they break and when they get strained, how we deal with them. This always happens first time. There we go. Your goal when we're dealing with these kinds of injuries is not to fix it. It's not to provide resolution. It's not to reduce the injury. Reduction is what we use as a term in the medical field to mean actually put the bones back in place so they can heal properly. Your goal is to avoid further injury, to reduce pain, and to get that person to definitive care without causing increased or additional injuries. That's it. And that means that we're going to approach this a little bit differently than a medical doctor would. A medical doctor wants to fix stuff. We don't want to fix stuff. We just want to deal with a situation. So that's what we're going to be focusing on today. Basically, there's four kinds of musculoskeletal injuries that you could run across in a typical scenario. One is a strain, and a strain is, just as it implies, straining the muscle. So you're stretching or contorting muscle tissue to the point where it gets damaged. And generally, this gets broken down. You don't need to know this, but it gets broken down in first, second, and third degree strains and sprains. Basically, a first degree is a modest damage or stretching to a tissue. Second degree is when you've got more severe partial thickness stretching of a tissue, and that's where you could also have bruising because now you got some bleeding happening in there. And that can be really painful, hard to walk. And you probably had one of those. I don't know, maybe you played soccer and something like that, and you damaged your ankle and it kind of got swollen and bruised up. That was probably a second degree strain. And a third degree is a full-on tearing of the muscle tissue, or the tendon. Tendons are the things that connect muscles to bones. And it's important that you remember that because we're going to be talking about tendons, we're going to be talking about ligaments. Ligaments are very different. So tendons, like muscles, can be strained in this way, and a third degree is a really severe damage that may actually require some surgical repair, but may repair on its own, but it's going to take a lot of time, and you're probably going to be immobilized, and it's going to be a miserable couple of months for you, right? Okay. The next kind of thing is a sprain, and a sprain is different than a strain. A sprain is damage to the ligaments. So the ligaments are the things that connect from one part of bone to another part of bone, and they are meant to stabilize an area. So unlike tendons that connect muscle to bone and therefore allow movement of joints, ligaments just connect muscle to muscle and are used to kind of hold things in place, if you'd like. Bone to bone. Bone to bone, sorry, yeah, not muscle to muscle. See, this is the problem. So anyways, when those get damaged, it's a little bit more problematic because they tend not to heal as well on their own. For a while, the common thought was that they aren't going to heal at all on their own. Now we realize that they actually do, but it takes some time and some appropriate care. The next kind of thing that we're going to focus on is fractures. And a fracture is when the bone itself breaks, gets damaged, gets chipped, anything like that. So often we think of fractures as like a full-on snap. And more frequently, it's not a full-on snap. It's like a twist, it's like a torque, it's like a chip, something like that. And then lastly are dislocations. Dislocations are when the joint gets pulled apart. So the two bones that used to work together like this are now kind of like that and not working together. And that also contorts the geometry of the muscles and the tendons, and therefore nothing works well. So typically in a dislocation, you have very limited, if any, motor movement at that joint. Okay, now here's the trick that you want to keep in mind. Everything I just described is going to be on a quiz. Everything I just described, you should know. But in the real world, it kind of doesn't matter because you're not the doctor. She is, and she won't be in the wilderness situation that you're in. So basically, if somebody has a joint that's really painful, that's not working right, that's all swollen up and black and blue, you don't need to know whether it's a fracture, a sprain, a dislocation. What you need to do is protect it, immobilize it, and get that person to definitive medical care. So it's kind of useful and helpful to be able to evaluate things because not everything's going to be catastrophic. Sometimes you're just going to be hiking and somebody's going to twist their ankle, and you will be able to help them out by looking at it and looking and saying, oh, I don't see any bruising, I don't see any swelling. This seems to be a first degree sprain, and you could impress them with your medical terminology, and maybe you wrap it up and they can kind of keep hiking. So to some degree, it matters in everyday life, and it matters in your growth as a human being to know the difference between a sprain and a strain. But in a wilderness emergency situation, we're going to kind of treat them all the same because we're not going to be diagnosing anything. We're just going to be caring for the person. You'll excuse me if I keep stepping up and coming down. It's just because the laptop has to be a little further away because as I show you stuff with my wife here, I need a little bit more range of motion. So that brings up this key point, which is we aren't doing diagnosis. And in fact, by law, I'm an EMT, so by law, if I went on a call and dealt with an emergency situation, I'm actually not allowed to provide a diagnosis. She can provide a diagnosis because she knows what she's doing. I clearly am a yahoo that's just strapping people into gurneys, so I'm not providing any kind of diagnosis. And if I'm not providing a diagnosis, you're not providing a diagnosis. The reason I'm kind of hammering that point is often when people get kinds of injuries in a wilderness scenario, so, oh, your elbow hurts, let me check it out. How's that feel? What the hell are you doing? You're not a doctor. Don't start tweaking and torquing things. You're just going to create possibly more damage. And I'm underscoring this because that damage could be severe. If she had a major fracture where you might have fragments of bone sticking out in different directions, and I start moving it like that, now I've just taken that fracture and swiped it right across an artery. So what was a modest fracture is now a major arterial bleed. And now we have a serious emergency. So you don't need to do anything like that. You don't need to cause any pain. Immobilize, protect, evacuate. That's our goal in this scenario. Okay, the kinds of fractures that are out there are on the video now. In a quiz, I might ask you questions about the kinds of fractures because it's kind of helpful to have some sense of how bones break. Having said that, I'm not going to talk about those because you can just look at those and see what they are. We talked about patient assessment before, and I want to underscore this point. I know, I did an hour lecture, more than that, maybe it was like an hour and 20 minutes on patient assessment. By the end of that lecture, you were probably like, oh my God, Hase, just stop. Well, now you're getting more of it. Basically, this is so important. And the reason it's important is because, A, it will give you some sense of how to care for the patient. That's really important. B, even more important is you might be the last person to speak to this patient before they lose consciousness. So you're going to bring the patient to the ER, and the doctor's going to say, tell me a little bit about what happened. And the worst possible answer is, I have no idea. I didn't ask. A better answer is, here's how the injury happened. Here are the symptoms. Here's how the person described the pain at the time. Here's the allergies of that person. Here's the medications of the person. And I know what you're asking. How would I know their allergies? Because you're going to ask before they lose consciousness. So it seems kind of weird to be in a wilderness scenario, 3 hours away from anything, and you're asking the person, do you have any major allergies? Do you have any previous medical conditions, et cetera, et cetera? That doesn't seem like the appropriate response to an emergency. But it is, and especially it is in these kinds of musculoskeletal issues because these aren't that urgent. What I mean is, if somebody breaks their arm, yeah, you need to get them medical care, but the clock is not ticking that fast. You can move relatively slowly, make sure the joint is secure, make sure it's stable, and bring them to medical care. You have hours, not minutes, to deal with this, which means in that time, you can also ask them questions. So let's imagine here, we'll do a little role play. Let's imagine that my wife Sherry here, Dr. Snekta, MD, has an injury. And so I come to her maybe, on a trail somewhere in the backcountry, and I don't know, she's holding her arm or something, and a couple of little tears are forming. Oh, isn't she good? She's holding her arm, a couple of tears are forming, etc. And what am I going to do? First thing I do is I start walking up to her and I assess her immediately. Now, at this point, you're expecting me to start asking about the arm. Okay, to be clear, right now, I don't care about the arm. She has an injury, and I'm walking up to her, and I'm thinking, is her airway clear? Is she breathing? Does she seem like she has good circulation? Don't forget the ABCs. These are the core. Don't fixate on the fact that she's holding her arm. She might have compromised circulation. She might have another major injury. Maybe she's holding her arm because she lost consciousness, fell on her arm, and you have to ask the question, gee, why did she lose consciousness, right? So I'm walking up to her and forming an initial impression, and the first thing I do as a medical professional, the first thing I do in testing is I say, hey, how are you doing? And the reason I'm saying this is because she's going to say,
not so good.
Excellent. Thumbs up. This is awesome. Because already I know she's got a clear airway and she's breathing. That's good. So already I've tested those two things. And then I come up to her and say, oh, okay, well, now I have to get her permission, her consent to provide her assistance. Hey, my name is Patrick. I'm an EMT. Can I help you out today?
Yeah, that would be great.
That's good because this video would be really short if she said no. So, okay. So she says yes. Now, next thing I'm going to do is say, looks like your arm's hurting. Can you kind of show me where that pain is?
Oh, it really hurts. It hurt my elbow. I was walking over these rocks and I just smacked right down on my elbow.
Awesome. Okay, so she's already given me the mechanism of injury. Look at the screen there, it says MOI, that's mechanism of injury. I really want to know how she hurt herself because it's going to matter a great deal for possible medical care. Again, I'm going to bring her to the ER and the doctor's going to say what happened. I'm going to say she fell from standing height onto a rock and hit her elbow, which is really different than she fell 30 feet out of a tree and seems to have pain in her arm. One is going to require full-on x-rays of every part of her body and all kinds of care and concern. The other is like, all right, let's deal with her elbow, right? So we want to get that sense of mechanism of injury. Then we want to go through the OPQRST. Yeah, I'm going to ask you about that on an exam for sure. And when we get together in person, I'm going to hammer that into you because you really want to get in the habit of asking these questions. We got the sample history and we got the OPQRST. Remember, the O first is onset. Here's a terrible way to start your history. What is the onset of this injury? What does it mean? So instead, you're going to ask a question like, wow, okay, so you were falling on the rocks and you smacked your elbow, I guess, right into the rocks?
Right into the rocks.
Oh, man, that sounds like it hurts. Well, listen, I've done a lot of care like this, and I've helped a lot of people out, so you're going to be absolutely fine. We're just going to have to kind of, make sure that we don't make the injury any worse, and I'm going to stabilize it to make it feel better. And then if it's okay with you, I'll help you get out of here and get to medical care. Does that sound all right?
I want to get out of here for sure.
Right. Okay. Now I'm not doing that because I'm bragging. I'm Mr. Expert. I've dealt with a lot of these. I'm doing that because I want to calm her down. And one thing I need to do is reassure her that I know what the hell I'm doing. So a bad response would have been, holy shit, your elbows hurt. Man, it looks really fucked up. That must hurt. Well, good luck. Right? So I provide her with a little reassurance and then I ask her some questions related to OPQRST. So that's onset. I know what the onset is, right? I'm going to ask questions then about the nature of the pain. So I'm going to say, oh, well, could you describe the pain to me?
Oh, it's really bad. It just won't let up. It's just like I feel like I smashed it or something.
Wow, is it really sharp pain?
Yeah, it's really sharp.
Okay.
Kind of throbbing too. Oh my God, it won't stop throbbing.
Oh, okay, good. Notice what's happening here is I didn't start by saying, hey, you have a sharp pain. I can give her some cues, but first I want to ask the general question, can you describe the pain to me? Because if I say it's sharp, if it hurts, she's gonna be like, yeah, it's sharp. If I say, is it a dull pain? She'll say, yeah, kind of it's a dull pain. They're gonna go with whatever you give them, right? So instead, open it up and allow them to describe it. The throbbing was awesome. A throbbing, sharp pain. Now I want to see if it's localized. Wow, do you feel pain anywhere else? Notice what I'm not asking. Is the pain radiating? That's what the R was, right? What the hell's radiating? Again, ask it in words she can understand when she's freaked out. Do you feel pain anywhere else?
Kind of up my shoulder a little bit, but mostly my elbow.
Okay, great. Well, you're doing exactly the right thing by holding it still. Keep holding it like that, okay? I want her to immobilize that injury. I'm going to immobilize it in a second, but I want her to first immobilize that injury, right? So ideally, if there were a friend of mine here or somebody else I was hiking with, I would have them hold it. But if nobody else is here, then the fact that she's holding it is just perfect. Okay. Now I want to ask about the severity of the pain. And basically, when we're asking about severity, we do use a fixed scale. So I said before, don't kind of prejudice her by saying, hey, is it a sharp pain? Is it radiating pain, etc.? But in terms of severity, we do want a fixed scale. And the reason for that is it will give us a sense of how it changes over time. So I'd say, listen, on a scale from 1 to 10, where 1 is no pain at all and 10 is the worst pain you could possibly imagine, what kind of pain is this?
I never had anything like this. This is a 10. This is the awfulest pain I've ever had.
Okay, so that's really helpful because then after I splint it, I'll be able to ask again, on that same scale of 1 to 10, where are we at? If she says 10, there's a problem. I'm not kind of helping her with pain. If she says, oh, now it's about a 6, awesome. If we then lay her down and kind of are in the ambulance getting around, we say, how's it now? It's about a 3. That gives us a sense of how the pain is moving. Is that a sense of how severe the injury is? No, we haven't fixed the injury yet. We're not going to fix the injury. We're just stabilizing her and getting to the hospital. But if we can reduce the pain and reduce the probability of additional damage, that's a good thing. So I've asked about the severity, and the last thing I want to ask about is the time at which it started. So to be clear, onset at the beginning is what was happening when this happened. Oh, I forgot P. I'll get back to P in a second. And time is just, how long ago did this happen?
Oh, like an hour, but it feels like a day.
Oh, wow, I can imagine, yeah. So, okay, so now I write down, okay, it's been an hour. That's gonna be really helpful. The P, which I skipped, but we kind of talked about, is provocation and palliation, which basically means what makes this better or worse. Now, what I'm not gonna do is, okay, let's see, does this make it better or worse? But I might say, listen, in the past hour, have you noticed if there's something that makes this better or worse? Does it feel better when you hold it tight like that? Does it hurt more when you stretch it out?
No, it just hurts. So if I don't move it, it's a little bit better.
Okay, cool. Cool. Here we all get this, right? Then the sample history. This is the part that seems a little bit weird because, like, all of a sudden I'm asking about medication and stuff, but I want to get this. And so I say, listen, before I fully start, I just want to get a little bit of information from you. I get a sense of what your symptoms are. So we've already done that because we did the OPQRST. Do you have any major allergies that you're aware of?
I don't have any allergies.
Oh, that's great. Are you on any medications?
I had some itching, so I took a Benadryl.
Okay.
I felt a little dizzy.
Okay, you haven't taken anything for the pain yet?
No.
Okay, so I've asked about that. Then I'm going to ask about pertinent medical history. Pertinent medical history. So I'm not going to say, look, you know, have you had any abdominal pain recently? When was the last time you were sick? I mean, that might be relevant. What I'm just going to say is, have you had injuries to that arm before or other injuries like this?
No.
No? And the reason that's helpful is because if she says, oh yeah, I've dislocated that elbow 3 prior times, the more you dislocate a joint, the more probable it is to be dislocated. So if she says I've dislocated 3 prior times, I'm suspecting a dislocation, right? So it helps to get some kind of background there. You want to know when she last ate. And at this point, that's kind of ridiculous. What the hell do I care when she last ate? But you want to know when she last ate and when she last drank something, because it's possible she's going to need surgery. And the surgeons, more particularly the anesthesiologist, is going to be really interested in when the last time she ate was. Believe it or not, you can sometimes have to delay really significant emergent surgery because the patient just ate too recently. Is that true?
Not particularly.
If
it's really urgent, we go.
Okay, fine.
Nervous, so.
Well, yeah, urgent related to elbow injury, fine. See, this is why she's not the least bit helpful. I just needed her for her elbow. Okay, so anyways, yeah, I mean, I exaggerate a little bit. My point is we don't want to have to delay any surgery any more than we need to, and it's really helpful to know. So I might just say, okay, I know this sounds funny, but when was the last time you ate something or drank anything?
Around 9 this morning.
Okay, great. That's really helpful. Okay, now we've got some of the history done, and now we can provide care. Now, if you look there underneath you, it's going to have some cues there for care. One is you want to calm the patient, where we talk about that. You want to kind of reassure them that you know what you're doing. You might want to assess movement, and you certainly want to assess pain. We've already assessed pain. We might then do something called PMS. There are other acronyms we could use for this, but I like PMS because it's easy to remember. Oh, is he in the video? Yes. Hi, Fozzie.
Hi, Fozzie.
As a demonstration device, I could actually literally break his leg, and then we could refill that. Okay, so PMS just basically means that I want to test pulse, motory, and sensory in the injury area. So what I might do is take this gently, and I might say, supporting it here, notice I'm supporting it at the elbow, open it up just a little bit. I'm not going to start moving it a lot. But if I open it up a little bit like this, and she says, ow, right, that gives me some indication that, okay, it's really painful, especially painful motion. At the same time, I could also check for crepitus. I could check for movement irritation, bone on bone. So if it's kind of a crunch, 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 it doesn't take a lot to move that. I can move that a few degrees, and that'll give me a real sense of whether it's painful or not. Now I'm going to check for PMS. So what I'm going to do is first check for pulse. So I got my fingers here, boom, 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 on the thumb side, checking for a pulse. And the reason I'm doing that, I know she has a pulse. She's upright, for God's sake, talking to me. But what does her pulse feel like in the extremity where the injury is? If she has some damage there to muscle, or more particularly to blood flow, then it might affect her pulse. So I kind of want a sense of that. I want to check her motor skills. So I might say, could you squeeze my finger for me? Okay, that's fairly strong. That's pretty good. So I know that she's got that. And then I'm going to do this trick. I'm going to say, okay, can you tell me which of your fingers I'm touching?
The fourth one.
That's not right. She's got to make it.
That's your fourth finger.
Starting
That's
with
your
the thumb?
ring finger. Yes.
Okay, I like
That's
this
the
finger
go.
better. Okay. So anyways, so the reason I do that is I kind of cover it up a little bit and I ask them which finger I'm touching. You don't necessarily need to do that. Some folks will just sort of say, can you feel me touching your fingers, etc. But to me, that's kind of vague because feel you touch, she's seeing me touch her fingers. There, you know, of course she's going to say, yeah, I feel it, or I kind of feel it, or whatever, even if she really doesn't. So if I instead kind of hold it like this and just touch a finger on the inside there, it's a better indicator of, yeah, she's got some motory and sensory function there. If she's not feeling it, can I do something about that? It just gives me a sense of the urgency. So we want to kind of know, can we stay in play or should we load and go? Basically, can I spend my time isolating this and maybe walk her out because this is not that serious of an injury? Or do I really need to kind of move her out quickly? Or do I need to move her out not that quickly? Or should I not even move her and see if I can get a helicopter to come to wherever we are? If she's got no sensory function at all, if she's got extreme pain when I move it even slightly, if it's starting to bruise around the injury, so it looks like there's some pretty severe bleeding happening there, then I'm going to start calling for a helicopter. If, on the other hand, she did as she did, just a little bit, ow, that hurts a little bit, but my motor skills are fine, my sensory skills are fine, then I know that maybe I could just take my time and load and go, kind of, isolate it, immobilize it, excuse me, and hike her out. And I remember actually one case in the Grand Canyon where we had a student from Stockton break her arm, and I hiked out with her about 12 miles. Then it took another 3 hours before we got her to a hospital. Was I panicked? No, it's a broken arm. She'll be fine. Like, there wasn't an indication of bruising. There wasn't an indication of severe inflammation. Okay, so I want to do that. I want to expose the injured area. So in this case, it's delightfully exposed. But if not, I can't tell if there's bruising unless the injured area is clear to me. So also exposing the injured area allows me to see, is it there? It's not there, but I'll cover it in a second. But also exposing the injured area allows me to see if there's any possible constrictions that might be problematic. So in her case, no rings. That's your right hand. I was about to give her shit for not wearing her wedding ring, but it's the wrong hand. Not wearing it there either, though. Which hand is it supposed to be? This one? No, I don't wear mine either. Anyways, but if she had rings, I'd be taking them off immediately. And the reason is we're likely to see some swelling happening. And if you got that ring, it's really going to constrict blood flow. That could be a problem. So the big problem at the end of this could be, in a severe case, that she loses a finger, even though the elbow is fine, because you didn't take off the ring.
We cut off a lot of rings.
Right. Yeah.
People don't like it.
Yeah, I can imagine. Yeah, I had that same case, that broken arm. The student had 2 rings on, and once I got her, I didn't try to take them off in the Grand Canyon because it was just too hot and her fingers were too swollen, and I didn't have any tools. Then once I got her up, I said, okay, I'm cutting off your rings, and she really didn't want the ring cut. She said, I'll take it off. Sure enough, we soaked her hand in ice water for about 3 minutes, and she was able to slip that ring off, but she was super determined. I swore if I would have done it, I would take it off 3 layers of skin, but she was able to get it off. That's fine, but you want to get that ring off. And then quickly assess the entire body. And I don't mean like expose the whole body and, hey, how things going, but I don't want to ignore the rest of her body. She just fell. It's possible there's a head injury. So I do want to say, okay, let's just kind of check back here, make sure there's no injury. Basically, you don't need to be weird and freaky about it. You can just rub your hand and then look at your hand for any blood. And you should, by the way, be wearing gloves. I didn't put gloves on, obviously, in this scenario, but you want to be wearing gloves. So I might run my hands down her spine, check for any stepping, that is to say, bone irregularity, especially in the C-spine area. I might be looking for any bleeding. I'm certainly looking for any bruising around the ears, around the eyes, anything like that. Anything that might indicate that she hit her head as well. Realize if she had fallen, hit her elbow and hit her head, she might be more concerned about a painful elbow than she is aware of a head injury. So it's your job to make sure that there's no other possible injuries. And we'll talk about assessing for head injuries in a little bit. But for now, I just want to remind you that you want to look at the entire body. As they say in medicine, you want to treat the patient, not the injury.
Can I jump in for a second?
Oh my God, go ahead.
So just to bring a little awareness to when you're touching other people, he's obviously my husband, and there's nothing weird. But if you were out in the
It's a little
woods,
weird.
if you were out in the woods and you instead of just touching a person, you want to ask if you can touch the person. And then it's really good because you're not focusing on the elbow and you're touching other things. Saying, I'd like to assess your head for any kind of bumps or blood. So now I like to go down your spine. I'm feeling for any breaks or injuries, like letting the person know why you're doing it. I'd like to look at your ear to see if there's any blood coming out. Nope, everything looks great. That's a nice way to add, and then not be creepy or anything like that.
Right. Yeah, we talked about that when we talked about price assessment, but it's really important and good to bring up. Let the patient know throughout the entire process what you're doing and why you're doing it. It's going to calm them down and it's going to save you from a lawsuit. So. But just because somebody said, yeah, I want your help, doesn't mean that they want your hand running down their back. Absolutely good point. Yeah. And there's the next slide. And as you can see in that slide, it talks about all the stuff we just talked about. Perfusion, I keep bringing this up, but in an emergency situation, it's perfusion. Why? Because it's shock. The real threat to our patients is the potential for shock. So we want to be evaluating them. So don't forget to check that radial pulse and then just basically look at them. Remember the kinds of signs we're looking for, right? Is the patient getting cold and clammy, diuretic, meaning sweaty? Is the finger okay? If you've got an O2 sensor, which I'll show you in person, you can put it on that finger and it'll tell you what kind, well, it'll give you one indication of what kind of perfusion you might be getting into that extremity. So anything that's going to give you a constant ongoing sense of how that patient is doing. And in this case, the patient, is your only patient, so you can really check on them every 5-10 minutes. If you look at the rule book, it says if the patient is stable, you can check on them every 15 minutes. If they're unstable, every 5 minutes. But in your case, what the hell else have you got to do? So keep checking on the patient and evaluating their perfusion and looking for signs of shock. And if you get any signs of shock, you need to deal with it right away. You need to hustle them to medical care, because now you're dealing with something that might be inconvenient to something that's life-threatening. Okay, general treatment, thank you for that. I'll get back to that arm in a second. Before we get on to splinting the arm, general treatment for these kinds of injuries include what we call RICE. RICE just means rest, ice, compression, elevation. So basically, if you tweak an ankle, if you tweak a wrist out in a wilderness scenario, you need to simulate this as best you can. First off, make sure you're allowing that area to rest. You can't have an injury to your ankle and then just say, screw it, I'm going to tough through this, because within hours you're not going to be able to tough through it, and it's just not going to function. You need to provide ice or cooling if you can, or wilderness scenario. Sometimes that just means stopping at a creek for a few hours and soaking that foot to try to control the inflammation a little bit. This is kind of controversial, the ice thing, because people often will then say to you, even physicians, crazy physicians, that if you got an injury, you should keep icing it periodically. I don't actually quite believe that that's good advice. As I'm looking at the evidence, my take on the most recent evidence on icing is immediately after an injury, icing can be beneficial, but then in terms of further care later, icing is beneficial if you're trying to reduce the inflammation so that the part can be useful and is functional, but otherwise, icing may not be your best friend, and there's nothing wrong with letting a joint swell up a little bit, because that's the body trying to heal that joint. That swelling actually increases blood flow to the area, which can promote healing. So icing immediately or cooling the joint if you don't have ice in a wilderness scenario, and you should have ice packs that you can break up. basically chemical packs that you break up and they create a cold pack. Or again, you go to a local creek if it's very cold and use that to cool the joint. That can be helpful, but I generally don't recommend that you do that, throughout the day for several days. Sharon, do you have an opinion on icing of injuries?
I have tried to look into this, especially with muscles. They used to say ice, 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 and I think that is gonna be going away. Joints, I don't think we've quite gotten away from ice, and joints may have a little more utility because you need the movement, the lack of inflammation, to get that joint improved, but I don't think we're done figuring out the ice issue.
Yeah. Compression could be beneficial as well. Don't get carried away with the compression. Back, when I was first training as EMT, we took ace bandages and went to town and really wrapped it up tight. Like basically, you walk on your ankle and it was completely immobilized because it was wrapped in 50 psi tape or whatever. Now you can step back a little bit without the compression. So if modest compression with an elastic bandage provides you with some security and allows you to hike out safely or provides you with some comfort, that's perfectly fine. But don't get carried away and don't leave it on too long, because again, the thing that's going to allow the healing, especially of a muscular injury, is blood flow. And so inflammation and blood flow to the area is actually desirable. And if you compress the area, you are inhibiting that blood flow. And then elevation. And elevation is the same drill. Elevation can provide easing of pain. It's sometimes really important, especially if you have excess inflammation. So if for some reason you got, I don't know, an infected leg and it's swelling up, into this massive thing and you're unable to hike out and it's super painful, yeah, of course, elevate. But if you've got an ankle that's a little bit painful, but not that bad, elevation, if it provides you some comfort and pain, might be a desirable thing, but it's not necessarily your first priority, because again, elevation means less blood flow to that area, and that blood flow may be desirable for long-term healing. Thoughts on any of that? Any of that, Ron?
I agree with the ice. I'm not so sure. I think compression and elevation are probably pretty good natural ways of decreasing inflammation, allowing still allows blood flow.
Yeah, and I agree, except that I think that's true, but there's indications that inflammation actually promotes blood flow.
Right.
So I'm just
promotes healing.
Yeah, exactly. Yeah, I'm simplifying things. Remember?
Yeah.
Intro to first aid.
Sorry.
So yeah, I totally agree with that, except that I guess what I'm saying is inflammation may not be your enemy. So don't be afraid to allow some inflammation to happen. It is, it's nature's way of promoting healing. And then avoid harm. Oh shoot, what is harm again? I can't remember. I can't remember what the H is in harm. I'll get back to you on this, but basically these are
expected on a test.
Yeah, right, exactly. These are the 4 things you should not do when you've got a joint injury. And A is alcohol. R is run, which just spells out harm. But what it's supposed to be is don't keep using it in the normal way. Allow it to rest, basically. So I guess the R could be rest as well, but it's things you don't do, so don't run on it. And then M, Sherry's gonna hate this because she loves these, is massage. Basically, if you got an injury for the first 72 hours, you should not be rubbing it deep or in any way irritating it like that. And what the heck is the H? I don't remember. I'll get back to you.
Hold, help.
Well, you want help, but these are things you want to avoid. Right.
Heat.
Oh, right. Thank you. Heat. Yeah. So the things you want to avoid then, to summarize this in a way that is coherent, is don't apply heat in the first 72 hours. Don't or avoid alcohol or other drugs in the first 72 hours. Allow it to rest. Don't run on it or other crazy things like that. And don't massage or any kind of deep muscle movement, because that's going to inhibit healing as well. Okay, spinal injury. So we got to that. So basically, whenever you're getting a muscular injury, that means you've had enough of an impact where you've broken a bone. Other bones that could be broken in that scenario, including bones in your spine. So we're particularly concerned about that. So we want to consider the mechanism of injury. My wife fell from standing to rocks. Not that concerned about spinal injury. Doesn't mean I don't want to assess for it. And if she were like 82 years old, I'd want to assess for it much more closely, but not super concerned about it. She falls off a rock and tumbles 60 feet and hurts her elbow. Now I'm much more concerned about spinal injury. So there's certain situations where you want to look at the mechanism of injury and then take spinal injuries much more seriously, depending on what the injury is. And you can see on the slide there, I've got them marked. But basically, anything that's going to be a jerking injury, anything that's going to be an impact injury, anything where you're going to fall from a significant height, like I would say that in a backcountry situation, more than 10 feet, you want to be prepared for that. Anything where you're thrown from a horse, that's how I broke my back. Thrown from a horse or other animal. In Yellowstone, it's not uncommon, not unfortunately, for stupid people to be thrown by elk and by bison because they get way too close. Literally, at one point, I saw somebody take their child and put them on top of a wild bison so they can get a photo.
Yeah,
So people are phenomenally stupid around wildlife. Lightning strikes, anything where it's really serious, and any kind of diving incident. So you're pulling anybody out of a creek or river or whatever, and they jumped into that, now they have an injury. Spinal injuries, very likely. And in particular, you want to watch out for injuries where they landed either on their shoulders or flat on their butt. And you might say, think the butt's pretty sturdy, that's a good place to land. It creates a significant abrupt compression of the entire spinal column. So the probability of injury to some element of the spinal column is really high with a butt impact. So you kind of, in those cases, want to suspect and pay close attention and provide basically spinal immobilization if you can. Now, back in the old days, again, I'm showing my age, but when I was trained, it was freaking stupid how focused we were on that. We had backboards, which were hard, solid boards. We put the person on the backboard, we strapped him in place. If somebody, here's the instruction we had. If you arrived at a traffic accident and somebody was in the accident and the car was crushed, and they were walking around, the driver's walking around. And so you get to the site and the driver's like, oh man, yeah, I got hit and really hurt and my neck hurts a little bit. We were instructed to do a standing takedown, which means you get the cops, you get everybody around, you get a backboard, they're standing up, you put the backboard up next to them, and then with a couple of cops and whatever else, you strap them in place and bring them down. Because they might have a spinal injury that they're unaware of, and you want to stop all mobilization. This is ridiculous. The safest thing you can do for that person is allow them to sit down in a gurney, lay down, and then, of course, immobilize their neck a little bit. Certainly put a collar around their neck to stop that kind of motion. And in person, I won't show you that now because it's hard to see on video, but in person, I'll show you how to put on a cervical collar to protect their neck. And that's something certainly, if you're putting together an extensive backcountry first aid kit, you're going to want to use. But we backed away from the kind of radical backward sort of stuff because what we've discovered is it's way overused. There's not much evidence showing that it's useful. In fact, the evidence of backward stuff dates back to the 50s, and it's basically based on guessing. Like somebody's got a back injury, they shouldn't move, so let's affix them to something that doesn't move. That seems to make sense. Let's do that. But it can create a lot of injuries, and it's certainly really, really bad for elderly folks who are just may not be straight in the first place. So now you're strapping them onto something that's straight, but their spine should not be forced to be straight. It can be really problematic for children, and it can cause bruising and other injuries. So as we look back in the evidence for the past 30 years, we see that extreme take caused more injuries than it avoided. For you, it doesn't really matter that much because you're not carrying a backboard with you. But you are going to probably be fabricating a stretcher or somehow moving folks out. So you do want to assess for back injuries because that will tell you whether you need to fabricate a stretcher, isolate, immobilize, and cushion that person, or whether you can allow them to walk out on their own. However, realize that it takes a lot of force, hundreds of PSI, to damage a bone. So you moving somebody slightly is unlikely to create a major injury. So don't let fear of intensifying or aggravating a C-spine injury stop you from providing care. When we talk about CPR, we're going to talk about how we open the airway, basically by tilting the head back just a little bit, opening up this area to provide clear airflow. And I encourage you in a prior class to kind of do, or lecture to do that. And you can feel how it kind of allows you to breathe a little bit more easily, right? Okay, that means I've got to bend the back of her neck. If she's got a spinal injury, you may not want to do that. So what I'm going to do instead, and we'll talk about this in person, is a jaw thrust maneuver. So she'd be laying down and I'd pull her jaw forward just a little bit to allow me to open up an airway. The reason I bring this up now is if that doesn't work, I'm tilting her head back. Because providing a clear airway, a patent airway, is way more important than the slight possibility that I might intensify a C-spine injury by tilting her head back. So big point here is in the past, we often did not provide, in my view, fully adequate care because we were really concerned about C-spine injuries. We should be concerned about C-spine injuries. I'm not negating that. But concern for C-spine injuries should not prohibit you from providing adequate care to somebody who is injured.
If somebody's not breathing, then their spine doesn't really matter all that much.
Right. Or what if they're bleeding? If they're laying on their back and in a pool of blood, you want to see where the bleeding's happening and stop the bleeding. And if somebody shouts, no, don't move them, that's phenomenally stupid. You need to stop the bleeding. Bringing somebody to the hospital with no blood in their body but a good C-spine is not your goal. So when we start then with spinal care, our first thing is the basics, ABC, airway, breathing, circulation. Modified jaw thrust, talked about that. If they have a helmet on, and I know that might seem weird in the backcountry, but obviously when rock climbing and other things, you might have a helmet on. When kayaking, you might have a helmet on. Leave the helmet on if you can. If you have to take it off to stop bleeding, to do a proper assessment, to provide CPR, then do that. But if the helmet's not getting in the way, you can provide CPR with a helmet on. There's no reason to potentially intensify an injury by moving the person around to remove that helmet. You want to, if you can, immobilize the head, neck, and back as well as you can while providing care, and I will show you how to do that in person. It's kind of hard to do that in a video. You want to check for PMS, we talked about that before, and general movement of the patient and wellness of the patient, and signs of circulation like the color, the temperature, and the condition of the skin. If the patient's head is at an odd angle, so do me a favor, can you lay down so your head's over here?
Kind of.
And then I know I got all kinds of crap there that we'll deal with in a minute. Okay, here we go. And tweak your head in a funky, weird way. So, in the interest of science, we have created a C-spine injury. This is good. No. But you can see if I run into a patient like this, and the head is really tweaked, and she's being gentle here, but you could really have a tweaked head. You want to support the head well, support the neck, and applying just a gentle traction, like I don't know what that is, 3 pounds of traction. Pull back into a midline position. That's all you're going to do. And the reason we're going to do that is because that's the most likely place for you to provide a patent airway. And if you need to provide CPR, that's the position the head's going to be in. And you're not going to be able to keep the head immobilized if it's tweaked over. So if you're going to put this person into some kind of makeshift stretcher, you're going to need their head straight. So once I've done that, then I'm going to take other material, whatever, I don't know, a blanket, something like this, and prop it on either side, and then maybe you put some tape over her head without putting the sticky tape actually on her eyebrows. People don't like that. On her head in order to immobilize it and hold it in place like that. Having said that, I don't want to wrap it so much that I can't reach her head, or tilt her head back a little. Tilt her head back in order to open up that airway. So that jaw thrust maneuver is basically a pull up like this. You'll be able to practice that on mannequins. That will help open up her airway, but if it doesn't work, go ahead and tilt the head back. That's what you need to do. You can control it a little better. So in a normal patient who's needs CPR, I'm just going to go to town and open that up. Maybe if I expect a C-spine injury, I'm going to support her spine a little and gently rotate to open up that airway. Right? Thank you. Okay, so we're going to do that. By the way, if you're wondering about those backboards, they are no longer used in New Jersey. So actually EMS providers in New Jersey do not use backboards except for extrication. That's true in New York as well and several other states. So what I was trained to do was strap everybody in a backboard right away. Now many states are saying you can't even carry a backboard with you. And if in states where they do carry a backboard, they're only used to say get somebody out of an auto accident or something like that. And as soon as they're out, you move them onto a stretcher.
You were on the backboard with the horse and you said it was awful.
Yeah, that's true. Yeah, so I got thrown from a horse, crushed portions of my spine, which hurt for sure. But then I was kind of fine. I called an ambulance because I wasn't able to drive, so I had to call an ambulance just to bring me to the hospital. As soon as they came, I told them my background, and I said, "Look, my eyes are equal and reactive, blah 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 blah." So they didn't have to do much of the work, but they did have to put me obviously in a collar, and this was several years ago, and they put me on a backboard. The worst pain I had by far was the ride in the hospital on the backboard. So my back hurt when I got thrown from the horse, and then it felt much better. It wasn't all that painful. And if I had just been able to sit in the stretcher, maybe a little bit upright, a 30-degree angle or something like that, we call Fowler, I would have been pretty comfortable. Instead, I had an excruciating ride to the hospital because I was on a flat board with straps holding me down, and my back was broke. So you kind of want to avoid that. Okay, so we're going to take a break here. And then in part 2 of this video, we're going to get to some hands-on wrapping up of Dr. Steckna to see how that works and how we can immobilize injuries to prevent further injury and to relieve pain. So I will see you in a few seconds.